All right. Well, let's get started. Welcome back, everybody. You're tuned in to the audio-vestibular case discussion group. And today we are going to be presented a discussion on migraines versus hydrops by the eminent professor Mohamed Hamid. Just before we start, just a quick disclaimer on things. Um, we are the audio-vestibular medicine group presenting monthly presentations via Zoom. I am one of the hosts, Gerard Gianoli, located outside of New Orleans. Mohamed Hamid is located near Cleveland, and Eugen Ionescu is in France. And we're the backbone of this, but everybody's encouraged to join in and discuss with us. The information is discussed is meant solely for educational purposes and not intended as medical advice for any individual. For individual medical advice, please seek the counsel of your physician. While these conferences are geared toward medical professionals, patients are welcome to listen and participate. However, we will not discuss individual patient cases in this setting. Please speak to your own physician for individualized medical care. And lastly, we will archive these discussions on our YouTube channel, which is listed here, youtube.com/@AVM Case Discussions. And so at this point, I'm going to switch over and let Dr. Hamid take over with his slides. And I think you got it now, Mo.
All right. Good morning, everybody. And thank you, Jerry, for starting this group and the continuation of it. I think it is gaining traction, and that's great. So today we're going to talk about endolymphatic hydrop. And some of the things that I will touch upon is production, recycling, absorption of the endolymphatic system, prevalence in health and disease, the clinical presentation in Meniere and migraine, and then talk about objective imaging, particularly that new 3D MRI that is gaining traction, and the testing, because there are some studies claiming that we should focus on 3D MRI first before any clinical testing for the diagnosis and management of Meniere's disease in particular. And we'll talk about a little bit presentation and management. Well, we all know that Netter diagram because it really shows the perilymph system, the endolymphatic system, and the temporal bone as we all know about it. We focus on the scala media, organ of Corti, stria vascularis, the mechanical to neurotransduction of sound, scala vestibuli, doing the vestibular conversion and contributing to motion, balance, and coordination. It's probably one of the most complex systems in the body, but we all should be familiar with the anatomy and physiology. The stria vascularis itself is the powerhouse in underlying the production of the endolymphatic system. The ion transport between the different layers of the stria vascularis is what maintains the electrical potential actually between the endolymph and perilymph. And when we talk about endolymphatic hydrops, that is actually a kind of the diagnosis by looking at the histopathology of the temporal bone. Clinically, it has its own presentation. And most commonly, the fullness, the hearing loss, tinnitus, and vertigo, depending on the extent of the hydrop itself. And the bottom line is there is an increase in the endolymphatic volume, ballooning, if you will. It gets to become like a balloon of the endolymphatic space. Whether it's increased production or decreased reabsorption, Um, it, it, the bottom line is increased pressure gradient between the endolymph and perilymph. There is a lot of transport of ions, exchange of ions, and the role of the cochlear aqueduct, vestibular aqueduct. Maybe all of the above contribute to the final picture of the histopathological endolymphatic hydra, as we can see in that slide. Um, so, hydrops, what's the definition, classification, and particularly in today's talk about differentiating Meniere's and migraine. Actually, also, there is evident endolymphatic hydrop in normal subjects without any clinical symptoms, and we'll talk about that later on. So, what in the clinical presentation, at least in my experience and the experience of many in the otology and neurotology field, ear pressure, fullness. You get a patient, my ear is full, looks like a balloon. Your exam is normal, your eardrum is moving, it's not a middle ear fullness. So that, to me, that's the primary presentation. And then the secondary presentation would be distorted hearing, tinnitus, imbalance, unsteadiness, vertigo. So, in other words, that's the histopathology of endolymphatic hydrop presenting as primary and secondary symptoms. Well, the evaluation. I think the history and physical, neurotologic, auditory, vestibular exam are very important. We use testing, audiometry, tympanometry, and reflexes, also acoustic reflexes, and also electrocochleography. And at least in my practice, I've been using the several frequency ECOG because it's like a stress test. When we do high frequency ECOG, we get the clear differentiation between the SP-AP ratio that we use for the diagnosis of relatively of endolymphatic hydrop. We also do caloric testing, cervical or ocular vamp, more cervical used than ocular. And that way we can get a more idea about what's going on in the system. Radiology, we're all familiar with the high resolution CT scan, reflecting temporal bone anomalies, MRI, whether or not contrast for tumors and Chiari. We're all familiar with this, but now for the 3D protocol, which I will discuss a little bit down the road today, is the new modality. It's about 10 years now. It's work in progress. The time and the cost of this modality remains high, and it's not universally available everywhere. It's actually not used yet in the two main institutions in the Cleveland area, and it would be interested to know what experience of other places. In the literature review, there is a high correlation with definite Meniere's disease. Interestingly, there is evidence of 10% that goes into the sensitivity of the test in asymptomatic subjects, about 30% positive in vestibular migraine, 20% in migraine itself. And we look at the radiology literature review. One published study implied that 3D MRI is more sensitive than audiometry and vestibular studies. And that is a little sensitive topic because these are not comparable tests, to be perfectly honest with you. The authors of that particular study did not take into consideration that the MRI is basically an anatomical study, whereas the audiovestibular tests are functional, reflective of the current status, activities of the disease itself that may or may not require additional medical interventions. This is a study that was interesting by Fan W. et al. From Japan. They used intratympanic gadolinium. Now, the 3D MRI for the endolymphatic protocol can use intratympanic or intravenous gadolinium. The difference is the time waiting and the potential quality of the pictures. Obviously, with the intratympanic gadolinium, we got much better pictures. This is an example from the same study. Right ear normal, left ear presumed Meniere's disease. And then it's giving, this is the study that's interesting. It's correlating ECOG. They did glycerol test to see if the hydrop would increase caloric test, CVAMP, OVAMP, VHIT, and they looked at positive agreements, negative agreements, overall agreement, and then the p-values. It's interesting with the ECOG, there is about 50% agreement. The caloric test, 55%, CVAMP, 40%, OVAMP, 32%. VHIT, which was interesting, showed about 10% with a more negative agreement. So when we look at the overall agreement between the 3D MRI, whether it's done intratympanic gadolinium or intravenous, it's really, when you look at the ECOG is correlating 50%, not very high, at 47%. So we need to keep that in mind as we begin to use that modality. Again, it's not widely used, and I would then, oh my goodness. Oh dear. Um, Something happened. Slides are misaligned here. So anyway, the next slide was really asking the faculty about their opinion. So the podium is for you, Jerry, and Eugen.
Eugene, you want to start us off?
But thank you. I think that, and in our practice, we use this new techniques of MRI, but the first place is the clinic, the vestibular assessment, and when we have to deal with a local treatment, in case if the medical treatment doesn't respond, that it doesn't function, in case of injections with dexamethasone or derivatives or corticoids, we generally perform an MRI, Hydrops sequences, but it is only to avoid or to exclude other concomitant problems, issues in the inner ear. We do not think that is indispensable for the diagnosis, but when you must to deal with a treatment, more aggressive treatment, imagery should be performed. I think also that migraine patients can have develop common migraine or vestibular migraine. It's like an amplifier for the minimal signs of clinical signs of hydrops. and very much patients which have vestibular migraine. In case of a good treatment for the migraine, they are very relieved in their audio-vestibular symptoms. This is my opinion.
Yeah, I've kind of gone back and forth on the MRI Hydrops protocol. Initially, I kind of thought to myself, if kind of along the lines of yourself, Eugene, where if they respond to medical therapy, it almost doesn't matter what the MRI scan is going to show. So is it worth doing the MRI scan? And then I got a little more aggressive in doing it. And unfortunately, the very first one we did was a lady who had unilateral hydropic type symptoms, and the scan was beautiful. The side that was normal looked completely normal, and the side that was clinically hydropic looked very hydropic. And then the ones I got after, the quality was just not as good, and I couldn't really feel comfortable interpreting them. And the radiologist didn't feel so comfortable either. And I couldn't justify the time or expense. And so I kind of stopped doing them, to be honest with you. But I do think one distinction, and Mo, you alluded to this earlier, is uh, the the scan is just going to show you anatomy. Hydrops is an anatomic pathologic finding that we would see on histopathology or now on an MRI scan. It does not presume a cause. For example, it could be Meniere's disease causing it, but you can also see it post-traumatic. You can see it after infections, et cetera. So there's other potential causes. So in our field, I kind of see things as three buckets. You've got anatomy, you've got physiology, which is the testing. It's telling us what's actively going on. And then the third part is the patient's history or symptoms. And you kind of have to put all of it together for a diagnosis. And I think each one individually, kind of doesn't support that stool. It's almost like the three legs of a stool. You need all three to kind of go together. Um, so just because you see hydrops on a scan doesn't necessarily mean they have Meniere's disease. I mean, it's in my mind, Meniere's disease is a clinical syndrome, and you can have hydrops on a scan, but have no vertigo, no fullness, no hearing loss, etc. In which case it really doesn't matter. Um, but I suspect probably the reason the big Cleveland hospitals haven't started doing it yet is the same thing. It's quality, expense, and I'll bet you, and I don't know this for sure, but I'll bet you that the reimbursement from the insurance companies is not particularly good for that.
I don't think that, to the best of my knowledge, Jerry, it's not covered by insurance. I don't
There
know.
you go.
I don't
And,
know
and
about your area, but
I will
neither.
guarantee you, Mo, as soon as the insurance companies cover
Yes,
it, everybody will be doing it.
yes. So, how do you? I mean, it's a very basic question. You agree that the sense of fullness is the first sign of endolymphatic hydrop?
I think in general, that's an early sign. I also kind of use it in my practice as a leading indicator of how the patient is doing. If the fullness goes away, I don't care if they're still dizzy, they're eventually going to get better. Because some of it is just uncompensated vestibulopathy they
Yes.
have. But I agree with you. I think it's a leading indicator. And I also tell them if you start to get that fullness in your ear again, we need to get aggressive with medical therapy, or you're going to wind up right back with your episodes of vertigo and such. So I agree with you. I think it is the leading symptom. Now, of course, there's no 100% in medicine. You're obviously going to come across cases where somebody doesn't have the fullness, or maybe their brain is just not perceiving it. We all come across those cases where they have classic Meniere's, except they don't have fullness in the ear. Those are exceptions, but not the rule by all means. So I agree with you.
Eugene?
I think that yes, I think that it's an important sign. This the pressure in the external auditory canal, but it should be differentiated because in my experience and Gerard talked about this patient which had the narrowed internal auditory canal. And in our experience, some patients which narrowed internal auditory canal, they experience a kind of painful pressure in the ear. And in my opinion, this is more likely to be in relation with an irritation of the intermediate facial nerve. So I look after these signs, but I try to take a look after. So in case of MRI, it's made sense to if you prescribe an MRI, I look after the signs. If in case of narrowed internal auditory canal, the of course the treatment is different.
I think Eugene makes a good point too, that, oral fullness, it may be Meniere's or Hydrops as a leading sign, but there's other things that can do it as well. Uh,
Mhm.
we've all seen folks with fullness in the ear, and you look in there and they've got a wax impaction.
Yeah.
Probably one of the more common scenarios, however, is eustachian tube dysfunction.
Yes.
And, as you know, a lot of these folks wind up getting a P tube placed, and by a general ENT doctor thinking it's probably eustachian tube dysfunction. And of course, these folks, they don't get any better. If anything, they feel like it's worse after a tube is placed, because now they've got a little tiny bit of a conductive gap from the tube on top of that fullness they already have. And I've had a few of those in the recent past where they basically want to, like, can you take this out? And I said, well, it's probably better just to let it go out on its own. But I think that's a very common scenario as well. And there's of course other things. And of course, the big thing every general ENT doctor is taught from the beginning is to watch out for the patient with ear discomfort and hoarseness who's a 50 pack a year smoker. And you have to, make
Sure.
sure they don't have a cancer, a laryngeal cancer.
Yeah.
Um,
Very scholastic, your commentary, Gerard. It's clear that I skipped because the very first time when a patient came to you, referred by the general practitioner, it came the idea that it might be an Eustachian tube problem. You maybe also observe the thing seems more likely to more complicated because in some Meniere disease we can observe a little transmission and a hearing conductive slight conductive hearing loss in patients which experience a little hydrops, and we see an irritative nystagmus, and but the tympanometry is normal. And
right.
yes, it's a very good point you emphasized here, Gerard.
I have a question for you, Eugene. So, you guys are doing the MRI Hydrops protocol. Are you doing the gadolinium intravenous or are you doing intratympanic?
That's a good
Uh,
question.
Intravenous normally in our hospital, it's intravenous.
and,
Intravenous.
and you
Yeah.
wait the 4 hours for the delayed
Yeah,
pictures? Okay. And
yeah.
you're happy with the results you're getting?
Uh, Partially, when you have the patient which is a good year, which is which is symptomatic, yes, we are happy. But we have, as you do already explained, and like Mohamed explained also, sometimes we had imagine imagery positive on the left side, but the patient it's clinically symptomatic on the right side.
Do you do you see a difference between the intravenous and the intratympanic? And then the other question here is, who is going to do the intratympanic with the radiology situation?
No, intratympanic, we didn't, we have no experience in it. And this is the radiologist will will mm, make the intravenous and with the team and radiology. We didn't. We have no experience so in
Yeah.
practicing the injection and intratympanic injections and imagery.
I'll be honest with you, Mo. I can't imagine intratympanic gadolinium protocols will really be very popular,
Yeah,
mainly because of the risk for permanent perforation, infection, discomfort, and the
Yes.
fact that you also got to get an
yes, yeah,
ENT doctor to do it. The radiologist is not going to do that.
and the patient is suffering when there are some teams which recommended to perform imagery when the patient is in crisis. So you imagine your patient, it's already dizzy. You ask him to support an intra-tympanic injection, and you also told him you must stay here. We will put it in the MRI machine. They are not very well when already, but putting in the machine in the horizontal position, I don't know. There are some arguments, and that's why we didn't try this technique.
I don't know. I've had intratympanic perfusion actually in my left ear when my speech discrimination dropped and it recovered. It's not a comfortable procedure. It's not terribly bad or anything, but it's not a comfortable procedure. And I cannot imagine radiologists actually doing the intratympanic injection with gadolinium. I mean, I don't know. I don't know if that would be even permissible. What are your thoughts about that?
I suspect, I agree. I just don't see the radiologist doing it. Now, that said, it wasn't that long ago that radiologists were not doing a lot of invasive things that they do now.
Exactly.
So, over time, I can imagine, yeah, they could be taught how to do an intratympanic perfusion. But I think the bigger issue is going to be, the extra risk of the perforation, especially you're dealing with someone who's got inner ear problems, and the radiologist does something that potentially affects the ear. It's gonna I can see a lot of radiologists saying, no, thank you.
Yeah,
You know,
backing off it. Yeah.
yeah. And the other thing too is again the insurance issue. I think that's a big hurdle with it, and just the cost and the time. Now, that said, I did read recently about a protocol. I want to say it's the UCLA group where they're doing it as a not delayed hydrops protocol. Now, that to me makes a lot more sense. If they can perfect that imaging, that way you don't have the 4 hour time delay.
Yes.
And if you can get good images of the inner ear, that I can see getting adopted really fast.
I definitely would agree with that because either the intratympanic or intra venous, that 4 to 6 hours window that you have to be waiting is too long. The other thing is, if I can ask you about it, the ECOG in this study was done with the far field electrode, not tympanic membrane or even intratympanic through tympanic ECOG recording. Oh, sorry. These recordings were done with a TM electrode.
Hmm.
So, what are your views about that? To try to quote unquote quantify endolymphatic hydrop. Do you use ECOG? I think is our only test for quantifying endolymphatic hydrop for the time being. So, your views about um, uh, TM versus far field. What do you?
Yeah, no, so TM is by far superior, I think, and even better that is the trans-tympanic,
Yes,
but
yes,
that's again, we
It's
initially
a
a
game.
long time ago we did trans-tympanic, but the problem again is then you're going to have to perforate the eardrum, you got the risk of and we eventually went to just TM, and that's going to give you a much better result. So the further you're away from the cochlea, the worse the results you're going to get.
yes.
And
Okay.
that's the biggest issue with electrocochleography is technical issues. And some of them you're just not going to get good results on, and then it's still left you wondering, do you have an abnormal result or not? But I agree with you. It's the only clinical test we have to help objectively identify endolymphatic hydrops.
Yeah,
And we use it. Now if it's normal, it doesn't mean they don't have high drops. But if it's abnormal, I think it's very likely they do.
yeah. And also when at least in my practice, when we do ECOG with TM, you can also get an ABR at the same time. But we don't
Yeah.
obviously bill for two separate procedures, and it's a reasonable way to do this. So, how about superior canal dehiscence and endolymphatic hydrop, Jerry? You're the world expert here.
Well, Eugene,
And yeah, just
is
No,
up there too.
no.
But I think it's a very common scenario in
Mm.
patients with canal dehiscence as well as other third mobile window disorders. In my mind, it's almost like represents a stage or a spectrum along the severity of the disease. Some of these superior canal dehiscent patients, they'll start off with no symptoms and they'll progress to like a typical minors type presentation where they just get sound or pressure induced dizziness, and then they progress to frank hydropic type vertigo spells that'll last hours at a time, which you can't justify hours episodes of vertigo based on the third mobile window theory, if you would. So I think it's a very common thing. And I know in the studies looking at MRI hydrops protocol, it ranges anywhere from 20 to 70 something percent of folks with SSED that have evidence of hydrops on the scan, which also kind of correlates what I'm seeing clinically in these folks. A fair number of them will have kind of a Frank Meniere's type uh, features to them clinically. I'm curious, Eugene, I know
yes.
you and I have talked about this before. I think you've echoed some similar thoughts to me.
Yes, I have similar thoughts, and even in other types of days, otic capsule dehiscences, we observe that there are patients which experienced, and we have. I present already. I think we had to deal with the patient which had vascular dehiscence between the internal jugular vein and the posterior semicircular canal, with the presentation which mimics quite well a Meniere disease. And the ECOG was positive, like in Hydrops. and we stented the patient with very good results. I have neither now. I think that when we performed this kind of uh, uh, a procedure, finally was something which seems like it's quite similar with the technique of Issam Saliba, which which he put the clip on the vestibular aqueduct, and he had some interesting results. But I would like to, we had a discussion with Paul Avan, Gerard, if
Yeah.
you recall, and we use ECOG on the tympanic membrane as you use, but we didn't perform systematically because we have a very good tool which is called Ecodia, and in fact it's about a system which allows to verify that there is not a shifting in the auto emissions in the spectrum of auto emission between the position in sitting position and in and,
Supine.
yes, and when this shift is important, there is a good correlation between the hydrops. That means that it's a hydrop, very possible to be a hydrops, Meniere type hydrops. So we had this, and maybe it will be interesting to invite sometime Paul Avan to explain a little bit how he reach to develop this kind of technique.
Yeah, that would be interesting. I know I shared with you guys, as in Mohamed and Eugene, a paper that was just published by Michael Gluth's group, looking at histopathology of patients in the past who had been diagnosed with clinically perilymphatic fistula. And he identified, I think it was about half of them who were able to identify some otic capsule dehiscence in these folks. The most common being cochlear facial dehiscence and superior canal dehiscence second. But I think it also talked about that clinical spectrum and overlap with the picture of Meniere's disease. And I
Yeah.
think it kind of, we're kind of getting to the point where, at least in patients with superior canal dehiscence and other third mobile window disorders, a lot of them do have hydropic manifestations. And so you can see how somebody with a positive fistula test who can have superior canal dehiscence and endolymphatic hydrops, and it kind of makes sense. It's sort of like the guys back in the day arguing, is it Meniere's, is it Parallel fistula? Well, they were kind of both right, which I think is kind of interesting.
Yes. I think at this point with the paralymphatic fistulas, what are your thoughts about the diagnosis and management of Eugene in France in general, in a region, about that concept of PLF and management?
But yes, and perilymphatic fistula. There are some techniques in MRI techniques, and which is I think that it's I don't know very well the techniques, but I know that they inject it with MRI injection, and after they look up if there is some modification specific to perilymphatic fistula. And then there are some colleagues, the surgeons, that will try to colmatate the internal wall of the wall of the medial wall of the middle ear, especially around the windows. But they are not very much finally fistulas that I was convinced that was a fistula.
You know, Mo, I would, you know, one of the things that I think is an important point here is if you have someone who's clinically got findings suggestive of a perineal fistula, I personally do not think that mandates you need surgery because a lot of these folks will do extremely well with just avoidance of straining, heavy physical activity, and things to lower the intracranial pressure. And I would say at least two-thirds of the folks I see in that situation do extremely well. Uh, and I think the ones that actually need any kind of surgical intervention is actually relatively low.
Yes,
Okay.
in my mind, I recall some person which had head trauma, and he had petrosal bone fractures, but not very important, and he had effectively a fracture of the stapes is an involvement. There was very clear that was because there were pneumatic. There was some air in the vestibule, and what was remarkable that the patient was not areflexic. They didn't become areflexic after, and he had effectively an auditory fluctuation, important auditive symptoms. And the surgeon, my colleagues, operated him with very good results. But they are not very much as I can remember.
Well,
Yeah, there is a question, Gerard, how third mobile abnormality could provoke an hydrops. I can try an response if you allow.
go ahead.
So a third mobile mechanism implies that the micromechanics of the fluids in the inner ear it's perturbed. There is um, much too much movement if in case in symptomatic patients, and I think that this could lead to a micro trauma to the saccules and the ventricles that are in the middle of the circuit, and I think that it's a kind of carrefour. Okay, it's kind of a local condition which we would conduct to more important a dilatation of the utricule and saccules. Do you have another explanation to add, Gerard or Mohamed?
I think there's a lot of potential, theoretic reasons why it can cause lymphatic hydrops. I mean, when you're having a significant pressure transmitted to the inner ear, you can get expansion of the the perilymphatic space for one. If you're getting, let's just imagine you're stretching out the round window and then you get a release of that pressure. The volume in the perilymphatic space is larger, and then it has to resorb, if you would, and you can see it resorb into the endolymphatic space. Two, you can also get a scenario where imagine you get enough pressure, you can get an intermittent perilymph fistula, and the volume in the perilymph goes down, in which case the endolymphatic space has to expand. You can also get a pressure differential between, like Mohamed was talking about in Meniere's, where you've got a pressure differential between the endolymphatic space and perilymphatic space. So I think there's a lot of potential reasons why it can happen. But the thing is, we know it does happen. That's the important thing.
Yes,
Yeah.
that we will already discuss that maybe even a little intracranial hypertension much could express a kind of hyperpressure in case, even in case of in case of day senses of not so big, and would generate a hyperpressure in perturbation in the over the paralymphatic space, and directly could lead to perturbation in the endolymphatic system also.
Sure.
Should we consider getting a high resolution CT scan as a even before audiometry or with audiometry when people present with ear fullness?
You know, I'll be honest with you. I'm pretty liberal in ordering a CT scan, but I think if they just have fullness, I think the first step is audiometry before a scan. You
Okay.
know, well, for that matter, too, almost all of my patients, I'm getting an audiogram before any kind of scan,
Right.
because
Yeah.
it tells you more about the physiology. You can imagine you get an audiogram and they got a conductive hearing loss and a B-type tympanogram. Well, you're not going to get a scan on that patient. You're going to treat them for an effusion. Or if they've got a negative temp, you're going to treat them for eustachian tube dysfunction. Um, but but that said, I am pretty liberal in getting CT scans. Now, if you're going to get a CT scan, though, you want to make sure it's well done because
Yes.
they are getting radiation with that. And
Mm-hmm.
you don't want to have to do it twice. And it's unlike MRI scan, which you can do as many times you want, and it's not going to have any significant negative effects on the body. From my understanding, high-res CT scans of the temporal bone, you do two of those and you're just below the level where they start seeing presenile cataracts, from the
Yeah.
radiation. Uh,
Mm-hmm.
Interestingly, I had a patient in this week who had his thymus radiated when he was a baby, and he wound up getting cataracts when he
Ah,
reached about 40 years of age. So, radiation is something to consider.
sure. Um, if we look at the slide about the study, I mean, they included the caloric test. And yeah, I think anybody who has some vestibular symptoms, the caloric test is just like basic audiometry, needs to be done. But what was interesting is uh, the correlation of the caloric test
Bigger. It's bigger, yeah.
is it's higher than the other, uh,
EKG.
perhaps more specific to Hydrops tests. And the numbers could be close, but when you look at the V-hit, that is, I am very interested in this. While the caloric test is a 55% correlates with the 3D
Mo,
MRI,
I,
the
I wouldn't
V-hit.
I wouldn't get too excited about that because a couple things. Number one is I bet you it wasn't a very large numbered study. I mean, I'm not familiar with the paper, but do you remember how many
What
subjects?
about 70 patients?
70. Okay, so it's not huge, but
That's
it's
a
it's
reasonable
it's
number.
a, it's a reasonable number. The second is you got to think about the patient population. These folks were probably picked because they looked like classic Meniere's patients, in which case they probably got picked because they had a caloric weakness to begin with. And as the caloric is on one end of the spectrum and the V hit's on the complete other end of the
Sure.
spectrum. So I don't know if I would be really all that wigged out about it. I mean, it's going back to originally what you said. They're trying to look at physiology and comparing that to anatomy,
Yes.
and they don't always correlate. It's like apples and oranges. Um,
So, if a group of people are saying that we no longer need to do the caloric test, the V hit is sufficient, what would be your response to them, gentlemen?
No, no, no. It's because we know that in Meniere disease, the VHT could be normal uh, till to some far stages of the Meniere disease. So I'm definitely we must perform caloric tests.
Okay.
I would tell them, ask your audiologist if we can do 8,000 hertz pure tone testing and you don't have to do 500 hertz. You
Yeah.
know,
Yeah.
it's different tests, you know, and you can have one's normal, the other's abnormal very easily.
All right. So for the general audience and those who would be kind enough to view our YouTubes, the caloric test and the VHIT are complementary, but
Yeah.
one doesn't replace the other.
The other.
All right.
Yeah.
There was something here about reviewing the questions. I think we don't have.
But we have a question on the chat. It says for patients that have hydrops and a migraine diagnosis, is it effective to treat these patients with migraine
Yeah.
medications, or are you just treating symptoms versus the underlying cause?
I think that I explained my position. I treat the migraine and see after because it's and a half of in our experience in AFA with patient which experience some hydrop signs and but they have common migraine. I treat migraine and the 40 to 50% they are already happy with the long-term medication for the migraine as avlocardiol or propranolol well, in case if there are not contraindication, of course. There are some drugs first line for the migraine and the second, etc. We definitely we must treat migraine because migraine potentialization the hydrops symptoms.
Yeah,
I would agree with that because migraine patients, some of them would have the hyperacusis, hypersensitivity to sounds, and that basically is processed through the inner ear, not through the brain itself.
yeah, I think, you know, symptomatic control of migraine just to me just makes sense, regardless whether they have hydrops or Meniere's or not. I have to admit, one of my favorite drug to use on these folks is acetazolamide because it kind of covers both things. It covers
Yeah.
hydrops and it covers
Sure.
Meniere's. And you know, I'm with Eugene. I think I even have a higher, you know, resolution rate than that just with acetazolamide. And I think it's because it does help both entities. But I don't think, you know, it's an either or. I mean, certainly patients can have both.
Yeah.
Uh,
And Topamax is also a carbonic
yeah,
anhydrase inhibitor. So
Right. Yeah.
that, right.
depending on the patient also, you can choose between the two. Yeah.
Yeah. I have a question. Did you use glycerol tests? Or
I did, we did not, even back in England when I was with Hinchcliffe. I think there are a few places in the world now where the glycerol test is done. What do you think, Jerry?
You know, we used to do it like really way back when in the
mm,
early days. I'm talking about in the late 90s. And it works, you know, but at the same time too, it's a temporary phenomenon. And I think it's helpful if you're not sure if medical therapy is going to help the patient, or if you're not sure the diagnosis. We don't do it anymore, and I guess it's
mm.
mainly because it didn't seem like it added a whole lot beyond the clinical information already. I'll be honest with you, if I really thought it would help, I would probably still be doing it because it's not a hard test to do.
Same for me. It's the same position.
I think that the emphasis on listening to the patient, taking good history, I would say 99% of the time you can diagnose Meniere's disease or migraine. And
Yeah.
despite the fact that 50%, at least in the United States population with migraine, have not had a diagnosis yet.
Well, I think one of the things to keep in mind is migraine is a syndrome. There's no biomarkers for migraine. It's
Yes.
just do they have the characteristic headache findings that are found in migraine patients? And if they do, I think it's appropriate to treat those patients. Now, just because they have migraine doesn't mean they can't have other things, like
Yeah.
we said, like Meniere's disease. And in fact, if you find someone's got, a caloric weakness or a low frequency hearing loss, I don't think you can blame that on the migraine. I think they've got a concomitant problem with Meniere's disease, and I think you have to treat both sort of independently.
Yeah. I mean,
Or use acetazolamide, which covers both.
yes,
Yeah.
that's true. And the CGRP receptors are widespread in the ears as well. So the connection between migraine and Meniere is there, and it depends on the clinical presentation, which uh, obviously migraine doesn't have at least in my experience, fluctuating hearing loss or tinnitus, but hyperacusis and motion sickness sensitivity and so forth.
I have a question for you guys. So, what do you think? I have some problems with the diagnosis of vestibular migraine where they have no headache. Do you guys have strong feelings on that entity? I know it defies the Barony criteria, but I know there's a lot of people talking about it's a migraine equivalent where they don't have headaches, but they get vertigo and phonophobia, that sort of stuff without a headache. Do you guys have a strong feeling one way or the other on that entity?
I saw some patients which have some equivalence, visual equivalence. They have a diminution of the visual, as in a migraine. And I treat it sometimes, and this patient experience a relief of their vestibular symptoms or stabilization. And I have another question for you, Gerard. How many time you treat? How long you treat your Meniere disease patient with acetazolamide?
I kind of look at it as long-term therapy. I tell the folks once we have you stable into a quote unquote happy place, I don't change anything for at least a year. And then after that, then we talk about maybe weaning off of things. Uh, and at that point, maybe about half we can wean off. The other half, as we wean down, they start getting return of the fullness in their ear. And it's like, nope, unless you want to have return of the vertigo, I'd continue. And that's kind of my protocol.
Does the presence or absence of large cochlear aqueduct bear on your decision, Jerry?
So I'm sorry, say again.
The presence or absence of large cochlear aqueduct in using acetazolamide, you kind of
So
consider it or not?
yeah, so if they do, and I'm concerned about that, the I would treat them essentially the same way with one big exception, is that that's someone who any major changes in intracranial pressure are going to get transmitted to the ear much more easily,
Yes.
like any other third mobile window disorder. And that's somebody I would have them avoid any kind of straining, that sort of stuff. So I have a whole handout I give them about things that I don't want them to do, like vigorous nose blowing, things like that. And I find that makes a huge difference for those folks. In fact, I have some of those folks where if they just avoid the strenuous activity, they don't even need the acetazolamide. It's kind of one of these things where they didn't realize that a lot of their normal activities were aggravating their vestibular problem. And once you cut out that, for example, like weightlifting, or Pilates, I can't tell how many times folks have come in saying, okay, well, how long have you had this problem? Oh, it started right when I started that Pilates course. And they didn't put two and two together and they stopped the Pilates and then their vertigo goes.
Yeah.
Eugene?
And I said, I use from time to time before I prescribe injection. I use also diuretics, but in France, as in Europe, we use very much beta-istine and a long course treatment, and it seems that it's a good drug for Meniere disease.
Do you use it long term, like I
Yes,
was
six
describing?
6 months, and there are some patients which unfortunately take every day. Even they are not symptomatics from now 6 or to 8 months.
What
How
about
high
you,
do you
Mohammed?
go on? Sorry,
I was going to say,
Gerard.
what's your protocol?
So it is for beta-istine 24 milligrams twice a day. So 48 milligrams per day. We actually prescribe generally in to stabilize the patient for 3 to 6 months treatment.
And Mohammed, how about you? What is your long-term treatment protocol?
With what?
In a Meniere's patient, you were asking how long would you treat him with the acetazolamide? What do you do as far as medical management? How long does it go on?
Well, I mean, lifestyle also, it depends. If it is, in my evaluation, I'd like to know if it is a salt sensitive versus not salt sensitive Meniere. I think that makes
Mm.
a good case for using a decreased salt intake, for example, or use of hydrochlorothiazide. Um, I am now more in my practice. I can, with evident low frequency hearing loss, I am offering patients to use dexamethasone. Unfortunately, there is no 24 milligram. There is 10 milligram. The 24 milligram is no longer available in the market, and that used to be really very, very effective. In my book, most of the data published there was based on the 24 milligram. Certainly, if they present to me and I don't have the luxury of seeing first many cases. I usually see them after a few years. If there is an evident speech discrimination deficit and patients are struggling with hearing, I use also dexamethasone right away, and I don't use hydrochlorothiazide or any of this. So it really depends. If the vertigo is the main problem and the hearing is reasonably good, I use a combination of dexamethasone and gentamicin, or just gentamicin alone. And usually one injection is not going to be major risk factor for further hearing loss. That's what I do with Meniere's. But patient's comfort, patient understanding, patient lifestyle, all of these with migraine as well, are becoming really very important in this patient population.
Yes, everything you mentioned here, guys, we used also. So we used also the diuretics, but in case of non-response and in case of patients which have still they have crisis Meniere type, we use before start the injection, we just put a transtympanic drain. And in some cases, only this measure will ameliorate the patient in 30% of cases. After that, they still continue to have some vertigo crisis. We start in case of a good audition with local steroids, and after that we have the gentamicin, low doses. We don't try to get the patient areflexic on the. We try to diminish the reflectivity of the vestibular system.
Well, I think we've had a great discussion and a really nice presentation, Mohamed, but we've passed our hour up, so I think we got to
okay.
close things.
Yes, we are.
And
All right.
okay,
So,
if you can stop your share, I'll put up the promo for next month.
right.
So this is, let's see. So next month we are having,
Are you having your screen now?
I think you got to hit stop share before I can.
Oh, stop share. You're correct. Here it is.
There we go. So I'll put this up. This is next month we've got Joel Goebel from who is professor emeritus at Washington University School of Medicine, is going to present a case of isolated utricular dysfunction, which I think will be interesting, and it is going to take place on February 20th.
20.
Friday,
Okay.
February 20th. So it's not going to be the first Friday, guys. And
Okay.
look forward to seeing y'all back then. Thanks for tuning in. Y'all have a great month, and we'll see you next month.
All right. Thank you very much, everybody, and enjoy
Thank
the rest
you.
of the day.
Thank you
Bye-bye.
very much.
Yeah,
Bye-bye.
thank you.
All right. Bye-bye.